This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers.
It's an emergency podcast. It is an emergency podcast because I'm going to get this out of my head. And if I don't get this out of my head, like, it's going to bug me all day. So
amazing
podcast it is. No
Dan's
meeting today.
Strung it on me. I don't even have my podcast outfit on. Dan does. That's true.
I know. Neither do I. Like, I'm missing the headphones. It's all on.
I could tell something was up, and
So my kids would call this one of my kids would call me this and say, "Dad, this is just your ADHD." And I'm just going to, as I say to them, I don't have ADHD. I have ADHW.
You're just missing one of the letters.
Attention deficit hyperactivity weaponized.
I was going to say a surplus.
No disorder in our household. It's a weapon.
It's true.
Okay, so what I want to talk about is two things. Two things happened in the last 24 hours, and I just thought it was worthwhile sort of bringing them together and discussing them because it's useful. And I think that the solution to it I've had for some time, and I figured I might as well share it. So
put it out there. All right.
Yesterday, I had a patient who uttered the words, "I feel overwhelmed."
Oh,
okay. And then this morning,
said every patient.
I was listening to a podcast and I heard a quote from Sir Alex Younger. So Sir Alex Younger is the former head of MI6, and he made this quote, which was awesome. "Helplessness in the face of complexity is the most debilitating thing." And I thought, oh my God, that is so what our patients experience. And it's what this patient was experiencing yesterday. What I wanted to share is, how do you manage the sense of feeling overwhelmed, and what do I do within my practice to help sort of manage that and sort of work through all that sort of stuff. So, and what is the consequences of feeling overwhelmed? So one of the things that happens when people feel overwhelmed is, and this sort of happened for them yesterday, was they get aggressive. So patients at times can be aggressive because they feel overwhelmed with everything going on. And if you've got multiple solutions for a problem, it doesn't they're
just as overwhelmed. Yeah.
They're just as overwhelmed.
Right. Yeah.
And so they had two issues that were interconnected. And for them, that made the situation overwhelming. Now, both you and I have patients that have 10, 11 diagnoses that are all interconnected. Yes. And which is sort of what made me think about the complexity statement from, Sir Alex, that, we have so many patients that have complex environments in which they live. They feel helpless, and that's absolutely debilitating.
Yes. Well, yeah. No, it's analysis paralysis, or paralysis by analysis too, where you get solutions, but it's daunting.
Yeah. What I wanted to share, and I know you've got your bits that you do as well, and there's, obviously different versions of being overwhelmed, but my basic approach to being overwhelmed is two things. Number one, you want to prioritize, and then number two, you want to execute. The problem with being overwhelmed is you've got to recognize you're overwhelmed first. So you are overwhelmed.
Right. Why am I angry?
You got to be overwhelmed to execute the solution.
Yeah.
Which is kind of crappy. But once you recognize that you're overwhelmed, step back, you got to prioritize, and you got to execute. I think what you can do there is you sit back and you go, okay, what are the problems? So you create a list of things that are going on for yourself, and then you prioritize it, and then you just choose number one and go with number one.
It's like you're explaining my coaching process, Dan. It's the weirdest thing.
Go.
Yeah. So you see all the problems, you pull out the most impactful / almost easiest in some ways, or reasonable to be able to address when you have the most limited capacity and you're the most frustrated and overwhelmed. And then you start to tick them off, so it's, what's in front of me and how do I start to tackle it in a way that makes it more bite-sized, and you're, approaching the most imperative / impactful stuff first. ideally, and then you just work your way down. We talked a little bit about this in the goal setting episode, I think.
But I think it was just like, it was just such a,
it's so common.
when
It's
a couple of things happen all at once and you're like, I got to get this out of my head. There you go. Got to get it out of my head.
Yeah, well, and like that's also, it ties into interoception too, right? Where can you recognize, it's like when you were dealing with patients that are sensitized, what's that feeling, the cognitive dissonance that comes before? And then if you recognize, oh, that's what's happening. I'm dealing with someone who's sensitized, right? So if you're a patient, it's like, whoa, how do I get when I'm overwhelmed? I don't do easy, basic things, right? I have a shorter temper. I feel more anxiety, blah, blah, blah. And so then just like with other things that you struggle sometimes to recognize, whether it's hunger or other emotions, right? This is one of those. And then if you can recognize, oh my God, I'm just overwhelmed. How do I make this less overwhelming? Whether it's increasing capacity, decreasing stress, or like Dan's talking about, prioritize the stuff that you have to deal with if it's literally situational. So yeah, I don't think anyone gets to not feel overwhelmed, unfortunately, at some point with this stuff.
The other thing that I was recognizing that I do about feeling overwhelmed, so when referring back to that sense of cognitive dissonance when I'm talking to a patient and I've been like, what is going on? At that point in time, being able to recognize, the patient is sensitized, work through the sensitization.
Right.
I think that, like, now that I've sort of, because we've been doing this for coming on 2 years, like, then creating that algorithmic approach to how you think through things. And
Right.
so what I think I will do is we'll chuck a link to my page that's got all my algorithms on it. And what they are is just all thinking tools. They're, in many ways, they're doctor thinking tools. They are my solution to dealing with feeling overwhelmed. So, and I think a lot of the people, a lot of people will say, so it's a trial and error approach. I'm like, no, dude, it is definitely not a trial and error approach.
No, not wrong.
So it's an algorithmic approach where we've sort of worked through yes, no, yes, no, yes, no, and we've got to start with this yes.
Yeah, no, I'm not doing trial and error with my folks either. Like, it's not random willy-nilly that you go through an assessment and then you just start working on, let's try that and let's try that and let's write. No, that would be a disaster. And actually that's what typically happens is you don't know where to start. You don't know what's most important. You don't know what's most doable given where you're at, or you have so many options that you just freeze. It's all too hard.
Anyway, so I think that, look, this could just be short, but at the end of the day, if you feel overwhelmed, the solution is prioritize and execute.
Have a plan.
And if you're a family member or a friend and you see that the patient or the person that you are caring for is overwhelmed,
right,
it's fine. Prioritize,
help them.
And if you're the doc and you can see the patient's overwhelmed, pretty simple. Prioritize and execute. And I think I think that's what we do, even if that's not 100% obvious that that's what's taking place. Anyway, there you go. Emergency is over.
Emergency has been quelled. Everything's okay.
Everything's okay. I feel better now.
Yeah, but no, I mean, there's different types of overwhelm. I think that's a good point too. Is it overwhelm with your treatment plan? Is it overwhelm with your life responsibilities? Is it overwhelm with your work responsibilities, right? And then where can you either outsource, delegate, have help, minimize responsibilities? It all is just different words for prioritize, basically, given the context and the setting. So I deal with it too.
You may, you just don't have more capacity.
Right. You can't just create more. That's the reality. Is there's limited ways. Right. Yeah. Plus, when you're most overwhelmed, you can't. So first, you kind of have to decrease the stressors in some way, shape, or form, and then rehabilitate yourself to having more capacity, and then you gain a little bit more freedom with what you can integrate. But yeah,
I find that in my own effectively 99% pain-free world, that I'll probably run life at about 100%. And it always annoys me when I need to put out 110 because I can't. I will for a couple of days and then I'm in a hole. So
there's only, you can't manufacture more hours in the day, right? You can use AI to get more done, but even that has a limit.
I was smashing it last week, and my wife said to me, "Do not complain to me on the weekend when you are asking me why you're so tired." Yes, dear. She was right, by the way. Anyway.
Yeah, that's hilarious.
Okay, so let's get on to it, because I'm punchy this morning.
Dan is pithy, as they would say in America.
There's two things before we get stuck, because we were not planning on doing this podcast today, because we wrote this about 4 weeks ago, and we're back into after I had another little
we've circled back around after Dan has reached another therapeutic moment, just like inspired the introductory part of this episode where we had an emergency episode because Dan was losing his shit.
And we weren't planning on doing this, but our editor edited the other episode, so we better get on with this one.
We're like, we should probably circle back then. So that's what we're doing.
So anyway, my entire brain has been literally has been in allostatic load.
It's such a dumb word, even Dan can't say it.
Oh my God. It is up there with stupid words.
With nociplastic.
Like nociplastic and nociceptive. Okay.
Yes.
Like
meaningless words to the vast majority of society.
So how do we make pain completely inaccessible? Let's give it some stupid words.
Conceptually, right.
Yeah. Okay. The other thing I wanted to start with was, what did you do this week?
Oh, you want to get into that? I played basketball for the first time in almost 20 years. So that doesn't quite tie into owning your care, but actually it does, because
it does.
Yeah, trying new things and like pushing yourself out of your comfort zone, and sometimes opportunity meeting preparation without you necessarily planning it is kind of what you have to take advantage of. Because Dan was like, well, what mindset shift led to this? And I was like, actually, I just kind of stumbled into this situation and I couldn't resist, and it was something that for the entirety of my chronic illness career, the last like 9 + 6 years was like a pipe dream. It was something I sort of never thought I would do when I was younger and playing competitively. And it was like my obsession and my passion. It was all about winning and being the best. And if it's not to win and it's not competitive, there was no point. So I never played intramurals in college. I didn't play for fun because it wasn't about fun when I was at that age and stage in my life. And then it was taken away and gone and not something I thought I could do. So
sure. So for those who'd like come into the middle of this podcast, maybe just refresh the jazz origin story.
Oh God. Yeah.
In 30 words or less.
Spark Notes version or elevator pitch. I had a traumatic brain injury 5 months after graduating college that took me the next 9 years to basically mostly recover from. I was on a million medications, did a lot of awful treatments, didn't want to be here, lost my sense of self, was very sedentary, got up to over 170 pounds, got down to 110. And then my reward for all of that was developing complex visual pain syndrome and all the stuff that comes along with that. So then that was the last 6 years. So before it was for, cognitive central sensitization related reasons that sports and athleticism was not any longer a part of my life. And then it was for largely physical reasons, right? I couldn't even gain weight.
All right. So that's so terrible. And the tone of your voice has changed.
I
know, it was 30 seconds. Tell me about the basketball again.
So we were out playing pickleball with a couple friends, and all of a sudden they started playing like, oh, we should play 4-on-4 because there's a basketball court right next to it. And I was ready to leave. I was there from 5 to 7. That was enough. My back already hurt. I was done. But then I was like, oh, maybe I could try like 1 or 2 possessions, but I was like, oh no, I can't play.
Who were you like shooting with before that?
An 11-year-old kid.
Yeah. What were you saying to the 11-year-old?
I was teaching them how to talk trash. And I was dominating.
Teaching them. You were teaching them. Okay. This
kid had the right mindset. I could tell. He was like a little mini me at that age. He was coming at me. So yes, I was first owning an 11-year-old one-on-one shooting, because that's what I thought the extent of my basketball safe zone was.
Yeah, great.
Never, ever did I imagine actually playing. That like never crossed my mind. And then when the actual adults started playing a little bit of half-court pickup, that's when I was like salivating like Pavlov's dog. I was like, I can't resist. And then I just, fuck it, like I'll try. And then 45 minutes later, I had gone as hard as I could, and old Jay came out, and it felt pretty good to be like the best at something that you haven't done in almost 20 years. It was amazing to have like the muscle memory come back physically, verbally. I was a point guard, so it's like organizing people and passing and just the court vision, and you just like I don't know. I thought that was gone forever. And so to have that feeling again and be able to experience it, I was like, I don't care how my body feels tomorrow. This was totally worth it.
And I thought my back would implode. Thankfully, it didn't completely. It was more just my lower leg was a little stiff. And obviously my ankle was super sore because I haven't used those muscles that way in forever. But that's like an appropriate response. So to have a normal response rather than a disproportionate, out of control, like, oh my God, I woke up in a ball of pain response was amazing. And yeah, I cried. I had an ugly cry once I got to the car and all the way home because I couldn't believe what kind of just happened. So
Well done,
yeah,
Jazz.
thanks. So it was
Congratulations.
unplanned, but
I know everybody is probably, most people are listening to this, not watching it, but Jazz got a big cheesy grin on her face, and it's nice to see.
yeah, thanks.
So
It was pretty cool.
Jazz. That's
Appreciate
really
appreciate
good.
it. Yeah, I mean, and like so much of what we're doing and talking about is about helping people be able, to get parts of yourself back and aspects of yourself, like take back what's yours, like
Yeah.
Dan has coined. And so that's why it was so meaningful, because it was such a big part of my life and my identity and who I was. And, just that feeling of like people in their different zone of genius, whether that's creative stuff or athletic stuff, whatever. So I found other things, obviously, to put my passions and joy into, but there's nothing quite like that. And so, yeah, it was really cool. So you can do it too, regardless of what your thing is that you thought was gone forever. Maybe not, maybe not completely.
Maybe not.
Just a little bit.
Awesome.
But
all right. Good way to start. What we were going to talk today. So out of the last emergency podcast, what we did is we were talking about what happens when you feel overwhelmed. And then really the simple process of then saying, well, how do you then prioritize and execute it?
How do you deal with the overwhelm, basically?
Yeah, how do you deal with the overwhelm? And so what we did is we put together what is essentially a reverse pyramid.
It's a technical term.
Which is about
top-down pyramid.
It's a top-down pyramid with how you can basically wanted to do is to give you a structure that you can look at and go, okay, I feel overwhelmed. I need to prioritize and execute. How do you then go through that sort of process? And what can you own yourself? What do you need a team for? And what do you need, specialist, more specific?
What is like a pure outsource?
What's a pure outsource? We'll put this up on the website. We'll also drop it into the show notes for everyone to have a look at. Jazz, take us through what is there? 1, 2, 3, 4, 5. There's 6 components to it. Do you want to just take us through briefly each component, or take us through the whole structure and go from there?
Yeah, what's nice about this is it's kind of like all of pain care at a glance. And one of the things that can make treating pain really overwhelming is that there's a ton of different components to it. And so what sort of inspired this episode, right, is what is your responsibility, and how do you as the sort of director of your own care team not only address the pieces that you have more agency and direct influence and impact over, but have a way to, like Dan touched on, outsource and delegate the pieces that you don't solely impact. What this structure shows is that you can't skip steps. And if you don't take care of the basics and do the very best you can with the pieces that you control, you're going to have diminishing returns often on the other pieces of the pyramid. And so what we start with is the basics, right? These are the pieces that I work on predominantly with patients, besides the second tier from a movement perspective. So the basics are kind of those: nutrition, hydration, recovery, pain education falls into there. So eat, sleep, drink, understand what you're dealing with from a pain perspective. That's why we've broken apart, right? Nociceptive, nociplastic, neuropathic components of pain, and control the pieces you can control to the very best of your ability. Go all in on those, and then see what you're left with. Don't not address those pieces and then try to get someone else to kind of save you with things that you have to address first.
Yeah. And so to simplify, just go through the goals. So what are the basic goals for each one? So if you're going, I've got to eat better, what are you got to do?
Definitely, if you have HEDS, protein, 1.2 grams per kilogram per day. That's a definite non-negotiable with hypermobility. But even without that, most people are woefully under-proteined.
Look, the 1.2 number comes from some data that shows that if you're unwell, you need 1.2 grams per kilogram per day. If you are listening to this podcast, you are probably the unwell bucket, unfortunately, or somebody who does and you're trying to help them out. So that's where that comes from.
Yeah. And then depending on performance goals, that'll vary a bit, but bare minimum, try to hit that. Fiber, 25 grams if you're female, 38 grams if you're male. Macros also fall into this around protein, fats, and carbs, and what percentage of your diet should approximately come from those. The ratio that I work on with folks is about a 30-30-40 split between protein, fats, and carbohydrates. So oftentimes, again, protein's real low, carbs are real high, and other micronutrients like sugar and things like that are also super high. Fluids, 40 milliliters per kilogram, or half your body weight in ounces, is a really easy way to break it down. Sleep, from a recovery perspective, 8 hours ideally is what you want to shoot and get to. That's why I work on a lot of things around circadian rhythm, anchoring, different things we've talked about in the sleep episode. And from an education perspective, understand your pain, right? What am I working with? What am I dealing with? Step one.
And if you're like, what do I do? Just go listen to one of the previous podcasts. Pick something that says neuropathic or nociceptive pain or body part pain. Just listen to it.
And the basics of conservative pain management episode, I think it was called, covers basically this, how appropriately named, the basics of this pyramid. Right? Look at us go. Yeah. And then the education piece is those types of pain.
Good on us for maintaining our branding. It's
yes. It's this consistency. Totally. All right. Tier 2. So once you've addressed all of those things, then you can start to, and some of this is a bit in parallel, but then you get more into the mind-body piece of things around movement, exercise, rehab, compensations, things like that, as well as the psych bucket of things around mood, stress, and the maladaptive behavior, which is very common, if not impossible to avoid once you have elements of central sensitization, because you fall into survival,
Before I get onto that bit, what I want to say, I don't reckon you need to do the basics before you do mind body stuff. I think that you need to go, hey, I need to do something, and which bit of this can I do? Right at this point in time, I don't have the capacity to feed myself because both my arms are busted, but I can sort out my head. Right. And so you can start at, how do you improve your coping strategies? And it might be that you need to go down to level 6 to do something, more specific for yourself before you can get back to the basics. Whatever. Just this is a structure for you to look and choose, I can do that. I'm going to execute on that.
Yeah. Ties into what is most accessible and realistic given your capacity and limitations. Don't just rigidly follow the structure of the pyramid. Yeah.
And so that brings us back to the question about what's maladaptive behavior. What do you tick into those boxes? What do you chuck into that?
Well, this is the one that gets such a negative connotation with pain patients too. But I think actually, why don't you dive into this one, Dan? The maladaptive bucket specifically.
It's pretty straightforward. You see it as catastrophizing.
Right.
You see it as substance misuse. You see it as self-harm and suicidal behavior. That sort of stuff. Oh, and loss of self-efficacy. So what's that? That's just loss of drive. There's times when you've got tons of drive to go, I'm going to sort this shit out. Let's go. And then when you're a normal human being and, you've got an enormous amount of pain and you're struggling just to get out of bed, surprise, surprise, your self-efficacy is substantially low. And so being able to recognize those maladaptive behaviors in yourself, that's hard. You have to look at yourself and go...
Self-awareness and honesty.
That's a lot of self-awareness. It's a lot of honesty. That's a lot of, that can be pretty brutal. And I think that once you get there, you can then go, okay.
I kind of need help. But not in the type of way that often happens once there is a lot of maladaptive behavior happening. Or I think this is then where patients in desperation, because they've lost that self-efficacy and drive, it's where you this is what happened to me over the TBI years, is I tried to outsource everything, right? I wanted and needed somebody to save me, but that's not how reality works. And so oftentimes that happens once you have serious maladaptive behavior going on, because all those other things are gone. So it's not your fault, but again, it's kind of your responsibility to pick out the low-hanging fruit that you can at least start to gain some of that back and get some confidence back, or borrow confidence from other areas of your life.
Yeah, I think that people can recognize in themselves when they've lost their drive. So when you've lost your mojo, basically, how do you do you have any techniques to recognize when you catastrophize? What sort of things that you might see in yourself that would say, hey, I catastrophize, or I'm catastrophizing?
When I'm in the hole and let's say, right, my back pain's really, really high and it creeps into, this isn't going to go away. I'm going to stay like this. I'm not going to be able to sort of unwind this ball of yarn and you get into that overwhelm, isolation, not reaching out for help, fear, right? Fear takes over rather than the other drivers in your life. So depression, anxiety going up too. It's basically anxiety going up, right? It's that, I'm not going to be okay.
Yeah. So on when I'm sitting on this side, what I'm listening for is I'm listening for things like my pain is 15 out of 10.
Right.
Okay. So then like automatically, like that's a trigger. And people use like in the words that they'll use, this is terrible. It is, I feel like I'm getting hit with a sledgehammer, blah, blah, blah. So where those words are like they're descriptive, if you can see yourself as going, I'm using these words.
It's happening.
It's happening. This is going to last forever, blah, 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 blah. That sort of stuff. You can then go, ooh, I'm catastrophizing.
I am catastrophizing, right.
And so that gives you a target. That gives you a target that you can then focus on to then start down regulating that sort of stuff. Because I just kind of see it as, it's the same as worry.
It's like extreme worry.
If you worry about something, guess what? The worry gets worse. Like
right.
So it's the same. If you catastrophize about something, guess what? It gets worse.
It's a cycle of catastrophization. Yeah.
Yeah. And just like recognizing that you've lost drive and you've lost your mojo, you can recognize in yourself by the words that you use and the way that you're thinking that you're catastrophizing, and that gives you a treatment target.
Right.
And as soon as you can find a treatment target, you can do something about it.
Yeah. And what interventions do I go to when this is happening?
Yeah. What can I read? What can I look at? Like, there's a million things.
What can I remind myself of is one of the big ones, because you've been in periods like that before. You've dug yourself out. You just forget. You get tunnel vision. You get very present in a not constructive way in this setting.
And to be clear, it is 100% normal to do these things. Okay. So I've got a friend, one of my friends who's a pain physician, recently got injured and was just like, dang, I was injured. Like he like me fights, right? So like he got something busted, whatever, probably a rib or something. And he's like, my brain just went to, I'm not going to be able to fight again. I'm not going to be able to do this. This is going to last for ages, blah, blah, blah. And he was like, I was catastrophizing. And he recognized it as catastrophizing because that's his job.
Right.
But he's like, but I know that I shouldn't be because I know this thing's going to get better.
Right.
What am I catastrophizing for? I think that recognizing it is a part of the whole pain process and the whole experience of pain. Yeah. It's okay. Don't blame yourself, but it is a target.
Right. Remove judgment, but notice it. Yeah. And for me, the other one is like, this is going to take me so long to build. I've slid so far back. This is going to take so much effort and it's just, it doesn't help. So it happens even to me. And like, I know this too from experience. And I also have these moments. So recognize it.
The other one at GJ is the setback. And I always reframe. So everyone comes into me having been doing really well and then they have a setback. And because they push it too hard. And my take on that is awesome. You felt like you could push it further.
Yeah.
You felt good enough that you could push it and you just weren't there yet. Okay, so what? Awesome.
Right.
You were nearly there.
It's like if I would have blown up. Yeah, it's like if I would have blown up in a total ball of pain post basketball, that still wouldn't have been a negative. It still would have been.
We still would have had.
I would have been salty.
You would have just been. You just would have still had the biggest cheesy grin on your face because you played, and you just would have been a bit more disappointed that it hurt so much.
Yeah, right. But
you're not. It's
back.
It's back. Look at that.
Okay. I had to calm myself down. Let's keep it moving. Okay.
Yeah.
Self-assessment and monitoring, tier 3. This is where you can start to use tools, wearables, apps, right? There's a lot of gizmos and gadgets available nowadays that weren't before. There's ones that are specifically geared towards chronic illness and chronic pain and that type of thing. And whether it's noticing symptoms and bringing awareness to that or tracking your sleep, calories, etc. We have things on here like various outcome measures around heart rate, HRV, oxygen, sleep, glucose, activity, like again, fitness tracking monitors. So these are things that you can largely gather yourself from a data perspective and then look at trends, pull meaning from, see things that you don't feel and you kind of need some data around.
I like this. We might even end up.
This is Dan's favorite tier.
Look, I'm only wearing 3.
Loves a good outcome measure. Yeah.
No. I think that this can
Me too.
be a way, and maybe we need to shift this where it is in the pyramid. But one of the things I really like about this is the assessment tools and outcome measure tools. So if you're sitting there and you're like, where the hell do I start? I'm overwhelmed. I need to prioritize something. Where do you start? So there's a set of outcome measures you can look at. So you can look at something like, you can download a DAS-21. So it's a depression, anxiety, and stress score. 21 questions. Do the addition for yourself, and it'll tell you like, how depressed are you, how stressed are you, how anxious are you. And you know what, there's a lot of patients that I see, they come through the door, they fill it out, and I'm like, you are coping like psychologically with this really well. No need to actually. I get a group of others that come through and their numbers are off the charts. You're like, great, we can address that. And you can do that for yourself. Right. Similarly, central sensitization inventory, that's one of the other things that we use. You can get on and you can just fill that out for yourself, and it stratifies your sensitization between mild and like subclinical through to extreme. And once again, it then allows you to go, wow, I've got tons of amplification going on in this thing. Right. I need to look for what these amplifiers are versus I've got no amplifiers taking place in this. I just need to find the bit that's sore. That allows you to go, okay, I need a guy or a girl or whoever that can just go and, do a diagnostic injection, find what's like doing this and treat it versus I'm really amplified. I've got pain everywhere. Doing a diagnostic injection is going to be completely useless for me because it's just going to make me worse. So it gives you ideas around that. The other outcome measure, which this is new for you too, Joss, is I found yesterday, which I really like. It's hot off the press. Is the psychosocial index. Very kind of interesting. Ooh. Yeah. Ooh. So the psychosocial index basically is 51 questions, which I was like, seriously. But most of them are yes/no questions. So it's not so it's pretty quick. And it does allow you to sort of break down, what are your psychological stressors? What are your social stressors? What are going on? And so if you go through that and you like, wow, I got a whole stack of like psych stresses. I got a whole stack of social stresses. It does pick up a little bit of catastrophizing in there as well. So you can pick up that piece. So it's things like that, which having that sort of set of things that you can just sit down and go, okay, where's my depression, anxiety, and stress? It's here. Where are my psychosocial stresses at? I'm there. I'm here. Where's my sensitization at? And it just allows you to start prioritizing what have you got to go after.
Yeah, you can see the pieces of your pain better. And we have a lot of these that Dan just ran through linked on, I believe, the sensitization page for that episode on our website, where you can just literally click the button and go to the DAS, go to those various
So we'll link to that
tests,
in the show notes and for you to be able to have a bit of a look at.
And to your point, Dan, why it might be good also elsewhere, maybe on the pyramid or further up, is because these are the things that to begin with bring awareness to the pieces of your pain without having someone have to help you, right? So it's not me going through an assessment, pulling it out for a patient and then prioritizing it and talking about it. It's you being able to do it on your own and go, oh, dang, I see, whereas before I didn't.
Yeah, so we're going to have to change the pyramid.
Perfect. Everything we do is forever changing, so it's fine.
All right. Well, the pyramid's changing in the episode.
In real time. Okay. Excellent. Okay. Anything else on that tier, Dan, before I keep it moving?
Look, I think that all the stuff at the moment that's around monitoring heart rate variability, all that sort of stuff, I think is really interesting.
Kind of looking at allostatic load.
Yeah, it is.
Looking at the capacity stressors.
Well, I think it's looking at capacity, and I think that one day, and maybe we need to have a whole chit chat around how you use these sort of monitoring tools to improve what you do. Because, and I think I probably said it before, like all these things that make you better and make you worse. Make you better and worse by somewhere between 3% and 6%. And unless you have some sort of tool that allows you to see that, it's very hard to tell.
It's too incremental.
So you can put together 10 threes, 3%ers, and there you're at. You're at 30% improvement, where if you utilize just one of them, you just can't recognize it. So anyway, we'll move on. That's a never ending talk and we'll go from there. But it is a little favorite of mine.
Yeah, well, it's not even seeing trends within a habit like your sleep trends, but what other variables in your life affect your sleep. It's way too minute to just like tease out from your own self-reflection, right? Memory is not the best
it's the
best data point. Yeah.
Okay, so next bit.
Mainstream diagnostics and treatments. So these are things like medications, injections, surgeries, things that are, quote, evidence-based, well accepted within the traditional medical community.
And I think the main point about this is when you're stepping outside, 100% of your own efficacy, and so you're now starting to get into delegation. So when you own something, you're going to be able to work in a team, so you'll be able to identify which part of the team, and then you can start to delegate stuff. So in this sort of setting, you're getting to mainstream diagnostics, mainstream treatments. What are you doing? You're delegating that knowledge base to somebody else. And that might be your GP, your physio, your allied health, your osteo, your chiro, your pain doc, or your neurologist, whatever. This is the point where you're starting to delegate. But still, the important bit is you're doing the delegating.
Right.
Like they don't own your care.
They work for you. And again, they work for you, not the other way around. Right.
Not the other way around. Right. That's the important piece here. You own the delegation. You own your care.
Right. And where, again, I see folks get into trouble and where I myself got into trouble was I largely skipped 1, 2, 3, and I went straight to help, save me, meds, treatments. In my case, not surgeries, but that can't make up for the earlier tiers of the pyramid.
And I think that
it depends on the type of pain, to be fair.
Look, at the point in time when you were initially injured, guess what? You needed to go to 3.
It would have been nice. Yeah. Right.
So there's but you don't have capacity to do any of that. Like, you're not like feeding yourself and like meditating and doing some self-assessments on your, traumatic brain injury. You're like, can you please save my life? Help.
Yeah.
That's where that's at. Unfortunately, a lot of medicine, a lot of these problems, it starts at, tier 3 in this, 2, 4.
Yeah.
You need to be able to build your capacity enough. You like delegating it to blokes and females like me. And then once you build your capacity, that brings you back to, okay, now where am I at? I can take control of my nutrition. I can take control of my mind body stuff. I can take control of my monitoring.
And those things don't take the place for having someone properly do this piece of things. Because this is where you have underdressed drivers and you can't mindset yourself out of, for example, an underdressed driver. So what are you doing for your rehab, psych, medications, procedures, surgeries? After that, we have alternative options, which typically are better to delve into once you have more or less exhausted the more traditional ones, but this also depends on, what are your preferences. Like Dan does a really good job sussing out with patients, and it doesn't mean you have to exhaust every single traditional thing before you try alternative things. But this is where you get more into personal preference. I would say the more alternative you go, because you're going outside of what is widely accepted and just,
This is very dependent on the clinician that you see. So I've kind of always seen my job's to get somebody better. And if you sort of look at the, evidence-based medicine, like the definition is the best available evidence, the experience of the doctor, and the preferences of the patient. So if you're in that setting, like let's say that you're at a point where the preference of the patient is, I don't want an injection, and I either respond badly to traditional medications or I just don't want to take them. Okay, so then you're at preference then you're at preferences. So my preferences is I'd like to use a supplement. Okay, so how my job is still to get somebody better. I need to do it still within the best evidence-based environment that I can. So my preference is a supplement. So then I need to look at what's the best evidence supplements, what supplements have got any evidence that are available. And so you go out there and you need to start looking at the randomized control trials around, omega-3s and fish oil, and you start looking, what is the randomized control trials around, Boswellia serrata, or what are the randomized control trials around curcumin and all that sort of stuff.
So alternative doesn't mean no evidence. It just
alternative doesn't mean no evidence. It just means like not mainstream pharmaceuticals. And so and the experience part of the evidence there comes down to what's the clinician comfortable with. Right. My rheumatology friends at the moment, even though like their world is inflammation, their focus will be, we're going to go through NSAIDs, methotrexate, sulfasalazine, maybe some prednisone intermittently, and then we're into all the new DMARDs or the monoclonal antibodies, right? And the data set that they are being provided with at the moment by the pharmaceutical world is amazing. Like, they are the new cardiology. Like back in the 80s and 90s, when we are driving, all the different statins, et cetera, all the antihypertensives, working through all that stuff. The data set that the cardiologists were delivered by the pharmaceutical industry was amazing, and allowed them to build this very strong evidence base of this is the best way to go about that. At the moment, rheumatology is the new cardiology. My God, the amount of data that they are being given by the pharmaceutical industry is amazing. But then if you've got a patient that comes in that says, hey, I don't want to use methotrexate, I don't want to use all these immunosuppressants. Right. I want to look at other, options. Other options. The preference of my rheumatology friends are like, look, I'm just not comfortable with that. The best thing for you to do is to do X, Y, and Z, which, you know what, that's clinician okay.
Comfort, trumped patient desire, but at least you're honest about, well, that's not where I feel comfortable. That's not where my skill base is, to your point.
I'm not comfortable to do that. I'm not going to suggest that you do that. The evidence base around that is weaker than
which is true.
The evidence base around this, which is true. That's where you start getting these pieces of conflict.
Yeah, I was thinking this, or dead end.
Between where, from a medical world, we're trying to sit in that, that evidence-based description of best evidence, experience, patient preference. When they don't match, you get conflict.
And that's where, again, then as the director of your care team, right, maybe you want a different rheumatologist for this purpose, or maybe, right? So it's not that they're a crappy doctor, they don't care, they were honest with you about what their skill base and comfort level is, and then if you want things outside of that, it might be time to pivot. So this also reminds me, I've talked about it before, but because of what I went through with the TBI and being on so many medications for so long, which completely screwed me up, I did not want to go down that same exact path with complex regional pain syndrome. So yes, I tried gabapentin. Yes, I tried other meds, but I wasn't going to be loaded up on Cymbalta and Lyrica and repeat the same, which were for me high side effect. If it was not, it'd be okay. So that got me to the DRG stimulator a little quicker than maybe someone else who would be okay with, because again, my physicality mattered to me. I was not going to get more sedentary like I struggled with before.
And so reasonable. Like, I had a patient come in just recently that was like, I do not want any medications. And I was like, yeah, okay.
That's gonna make
there was a hard stop on it, and there was like that. And I was like, okay. The problem I had at that point in time is that in my head I was thinking, we need
the best thing would be,
we need some medication here to sort of get her across the line. Yeah. But her hard stop was because as a kid, she had a condition that required large amounts of prednisone, for which she had an enormous amount of complications from, and had a whole stack of prednisone withdrawal issues and blah, which I've never seen before. Yeah. I didn't even know you could, I knew you could, you can withdraw from prednisone, but that's because you get so much adrenal suppression. Oh my God.
Yeah.
But you listen to further down into the history, I get that part of the story. And I was like,
this makes sense.
I get it. Your preference is you don't want to live that crappy life again.
Right.
That is 100% cool. Let me see what I can work around.
What else can we do?
What can we do for you? So it's okay. Just because we as doctors might respond initially with, we got to go down this track.
It's a slight distress.
It's a lot of the time. It's a lot of times because we don't know. So, and I suppose that's then back to you as a patient if you're like, hey, I really don't want to do this, and they come back and they go, hey, I suggest we do this, you need to tell us why. Just tell us why.
Right.
Most people
right,
are
right.
like, if you
Add context. It's not
add
just being
context.
difficult. I'm not being a difficult patient. I'm not, being stubborn or whatever. It's for a reason. And most doctors then understand.
Like, and I've had patients that have said, I do not want a procedure. And then sometime we get into it's because mum died during getting a procedure. And it's like, okay, I get it.
That makes sense.
Let's pivot,
Right. Yeah.
you know.
Okay.
The other thing I've done as well, just on that note, is then getting to a point where we recognize that that is a block for us and that we've got a phobia, we've got maladaptive behavior, or we've got maladaptive thinking.
Trauma, right? This is right.
Yeah. And that, and I go, okay, great. I get that this is where you're at. Right. We need to get you to here. The path to get there is going to involve walking this. Right. We need to get rid of the blocks. And so that's where we can engage with the psychologists, with the blah, 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 to get them to help us get through that block, which then helps you get to being better. So once again, it's fits and roundabouts, and you just have to identify what it is that we need to do for you. Pivoting is one option. The other option is, well, let's just sort it out.
Yeah, or work through it. And this too is where trust with your clinician and the ability to be honest, and talk about some of these things and sometimes work through it, and sometimes just go, well, then it's not going to be the best option.
Yeah.
So it goes either way.
All right, last bit.
Okay, last bit here. Now we're all the way into precision med. So this is actually an interesting area Dana's quite passionate about, and we'll probably pull out into another episode at some point on a whole bunch of other stuff in general. But personalized basics, right, through two alternatives for disease treatment and prevention strategies that are based on genetics, environment, and lifestyles factors completely specific to you and that have measurable biomarkers essentially, and things that, whether it's, again, biofeedback or apps and whatever tool allows you to see those things, you've now gone from more broad, basic, right where we started, it kind of applies to everyone and is sort of a non-negotiable. Whereas at this very bottom of the pyramid, you become hyper individualized and hyper specialized basically to your exact situation and your exact preferences and things that are not looked at necessarily in the mainstream at this point as much, but hopefully we'll get there.
And this is where, precision medicine's been around for some time now, and the concept that you effectively hyper individualize your management to your genetics, your microbiome, your blood work, your etc. It's just that it's so complex. We haven't got there yet. And the other thing is that
access to
it doesn't fit into a standard randomized control trial setting. Like it's very hard to do randomized control trials on precision medicine. You can do it, but it's difficult. And so it doesn't fit into the current, evidence-based approach model of medicine. But it's where AI will fit in. This will be the role of AI in the future in medicine. Other than getting rid of doctors, which that's not going to happen. But
bunch of busy work. No, don't get rid of a lot of the roles and things you guys have to do, but
that's a whole other discussion. I don't think that AI gets rid of doctors. I think it makes us better is the thing, because I think it will assist with managing complex patients where
talk about pattern recognition.
So that'll be, but it'll just make it better. So all right,
so
that's it. That's the ever-changing inverse pyramid.
It's a version 1.5. And if you break it down, it's a bit further other than where we started, where the catchphrase that's easy to remember, right, is overwhelmed equals prioritize and execute. What do each of those individually mean? As far as prioritize, most to least important, which is basically your goals, right? Easiest to hardest. And then execute, own it, teamwork, delegate, but you can't.
But you got to own it.
Otherwise, everything else becomes pretty difficult. And if you're looking at the pyramid, right, you as the patient are in every tier for that reason, because you kind of want to draw through that ownership even when you are outsourcing and even when you are delegating, because you're still in charge, let alone when it's the basics that nobody else can do but you. Your pain doctor can't literally fix your diet or your sleep.
We'd spoken a little bit before about self-efficacy. And that's about owning your care. And so if you're listening to this at the moment and you're like, I'm not owning my care, then that's your, we've got to help build your self-efficacy.
And this is what helps you build your self-efficacy. There's a really good, oh God, it makes me think of a quote from Recovery. What was it called? Self-esteem comes from committing esteemable acts or something like that, right? You don't just get self-esteem from nothing. You get self-esteem from doing esteemable acts and things that show you, oh, I could do that, or oh, I could control that, or oh, I could impact that. And so that becomes a positive cycle in the right direction. And you have to kind of start small and start with what you can and then build over time. And then you're taking ownership over bigger things like my movement program, rather than just drinking enough every day. But start with just drinking enough every day. And then you're like, oh, damn, I could do that next. And build and build. Perfect. So all right, that is our pyramid. All right.
And let's go fix it now.
Let's hang up and work on it some more. Yeah, that's how everything gets developed here. All right. So, yep. We will see you next time on It's Done in Your Head podcast. Thanks for listening.
Thanks,
bye, guys.
Bye.
Bye, Dan.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.